Hello friends, and welcome to the Head and Neck Oncology Journal Club. I am Krishna Kumar Thankapan, this time with a companion podcast to the surgical video on superficial parotidectomy for a pleomorphic adenoma on the right side. Today, superficial parotidectomy, but not simply as a sequence of steps. I want to go through the operation the way it is actually performed, and at each stage stop and ask why it is done that way. Why the plane changes as you move across the face. Why the nerve is inside the gland at all. Why we take layer after layer of tissue between the two landmarks instead of going straight for the trunk. And why the complication that troubles patients most is not the one you are dissecting around. Starting with the tumor, before the incision, a word about what we are removing because it dictates the extent of the operation. Pleomorphic adenoma is benign and it is encapsulated, but the capsule is the problem, not the reassurance. It is complete in places, variable in thickness, and the tumor characteristically sends out small extensions through it, pseudopodia. Satellite nodules sitting just outside what looks like a clean surface. This is why enucleation was abandoned. If you shell the tumor out along with its capsule, you leave those extensions behind, and recurrence after enucleation is not a single nodule you can simply take out again. It is multifocal. Nodules scattered through the operative bed, in the scar with the facial nerve already dissected once and now encased in fibrosis. That is a far more dangerous operation than the one you are going to see today. And with enough time, recurrent disease carries a real risk of malignant transformation to carcinoma ex pleomorphic adenoma. So the principle is a cuff of normal parotid tissue all around. Superficial parotidectomy is not over-treatment of a benign tumor. It is the operation that ensures you only have to do it once. Why the nerve is inside the gland? Now the anatomical oddity at the center of everything. No other salivary gland has the motor nerve running through it. The reason is developmental timing. The facial nerve is already in position, coursing forward from the stylomastoid foramen before the parotid enlarge has grown to any size. The gland then develops around it, extending medially past the nerve. Two consequences follow, and both are practical. First, there is no true anatomical lobe. When we say superficial lobe, we are describing a surgical plane, not an embryological structure. There is no facial layer there, no septum, nothing to open into. The plane exists only because you create it along the surface of the nerve. Second, this is why the operation is what it is. You are not removing a gland that happens to have a nerve nearby. You are performing a nerve dissection and the gland comes off as a consequence. Everything else in the operation is set up for that. The incision and the flap. The marking is pre-auricular in the first anterior crease, curving down into the first transverse neck crease. The anterior limit is set by the anterior border of the swelling. The disease defines it, not the habit. The angle of the mandible is also marked as a surface landmark. We do not usually extend posterior to the pinna. That extension buys little exposure and raises the risk of flap necrosis at the tip. Then the flap. Here the plane changes as you travel across the field. Pre-auricularly, you are supra-SMAS, the superficial musculo-aponeurotic system. The plane the surgeon calls fat up, fat down. In the neck, you are subplatysmal, and those two have to be connected as you come around anteriorly. The SMAS is worth a movement. It is a continuous fibrofatty layer investing the muscles of facial expression, and the platysma is its inferior extension. The same sheet, different name in a different place. The facial nerve branches lies deep to it. That single fact is the whole safety argument for the flap. Stay superficial to the SMAS and the branches stay protected beneath. which sets the trap. If you dissect meticulously along the subplatysmal plane and simply keep going, you will find yourself sub-smash in the anterior face, deep to the layer that was protecting the branches, exactly where they are most superficial and most vulnerable. Careful dissection in the wrong plane is still the wrong plane. The transition upward has to be deliberate. Now the great auricular nerve. Before the parotid work begins, a step the patient remember for years. The great auricular nerve arises from the C2 and C3, wraps around the posterior border of the sternocleidomastoid and runs up to divide into the anterior and posterior branches. The posterior branch supplies the lobule and the skin over the mastoid. The anterior branch will have often to be sacrificed. The posterior branch usually needs to be, and preserving it matters more than operative time it costs, particularly for women who wear earrings. Numbness of the lobule is what patients notice at 6 months, long after the incision has faded. Technique: start at the lobule, find where the nerve enters and trace it downwards to the main trunk. Seeing it is not enough. It needs a full 360-degree release from the bed and has to be laid aside posteriorly out of the field, preserving along its whole length. 2 landmarks and what each one is worth. Now the central problem, where is the trunk? The tragal pointer reached through the superior tunnel, begin in the pretragal area, in the loose areolar and the relatively avascular plane, staying out of the perichondrium. Monopolar is safe here. Separate the fascia anteriorly with traction and make sure all the parotid tissue moves forward with you. For the last part, put the monopolar down and define the pointer with a sharp elevator with the tragus retracted. Irrigate before you assess it. The relationship to remember: the nerve lies roughly 1 to 1.5 centimeters antero-inferior to the pointer, little deep. But be honest about this landmark. The pointer is cartilage, soft, blunt-tipped and easily distorted by the retraction you are applying to see it. It gives you a direction, not a destination. Cadaveric and clinical work has repeatedly shown it to be the least precise of the described landmarks. The posterior belly of the digastric reached through the inferior tunnel, incise the fascia over the anterior border of the sternocleidomastoid completely and separate it forwards. Sternocleidomastoid clears first. Anterior to it, and specifically its superficial aspect, is the digastric. It's a more reliable landmark than the pointer because it is a muscle with a fixed bony attachment to the digastric groove, and the trunk lies approximately the depth of its upper border. The stimulator, the nerve stimulator, what it is actually telling you. Once the digastric is identified, activate the stimulator and test it against the muscle. Watch for the twitch. Note what the step is for. It's not to find anything. It is to confirm the device works before you start relying on it. A stimulator that has failed silently is more dangerous than no stimulator at all because it converts every negative response into false reassurance. 2 points of physiology. Current spreads through the tissue, so a response can come from a nerve some millimeters from the probe tip. Useful when fishing. Misleading if you read it as a precise location, and the stimulator depends entirely on a functioning neuromuscular junction. If the anesthetist has given long-acting neuromuscular blockade, you have surrendered this safety check before the knife touched the skin. That conversation happens before induction, not during the dissection. Now, working between the landmarks. You now have got 2 landmarks and the nerve is in the tissue between them. That tissue comes down 1 layer at a time and every step is stimulator guided. The method is repetitive by design. Make multiple tunnels. Take the tissue in between. Test each layer. Only after there is no titch, coagulate with the bipolar and cut. Then the next layer. Taken, tested, bipolar, cut. Then the next. As you close in, there is a maneuver worth naming, nerve fishing. Touch a little deeper with a stimulator and watch. A twitch tells you roughly where the nerve lies and you redirect accordingly. This is a stage that tests patience rather than dexterity. Stay with it. At some point, the stimulus comes and the nerve is there. Pearly white, 1 to 2 millimeters across with a fine longitudinal vascular pattern on the surface. Expect an arterial spurter as you approach. It has to be caught and clipped cleanly, never controlled with a blind cautery near the nerve. It did not occur in this case. The trunk, the kick and the branches. Confirm with the twitch of the main trunk which moves both upper and lower face together. Then the inferior kick. Take the inferior parotid tissue lying below the nerve, stay on the nerve, direct the tonsillar artery forceps posterolaterally, and that releases the tissue and exposes the trunk further. It follows directly from the definition of the operation. Everything lateral to the plane of the nerve is coming out. Next, the bifurcation into the upper and lower trunk, temporofacial and cervicofacial at the pes anserinus, usually with a centimeter or so of the foramen. Branching beyond that point is highly variable. Davis and colleagues reported 6 distinct patterns with the interconnections between the branches in the majority of specimens. The practical translation: do not dissect from a memorized diagram. Dissect what is in front of you and expect interconnecting branches rather than being surprised by them. For each trunk, the principle is identical. Stay on the nerve. Take the tissue above the instrument. Bipolar cut. For the lower trunk, keep the nerve under the tip of the artery forceps. Dissect gently, push forwards and come out. And when you bipolar, hold the instrument with an upward thrust so that energy is directed away from the nerve lying beneath. That upward thrust is the safety margin. And a point about the injury mechanism that changes how you handle the nerve. Most postoperative weakness is not transection. It is the traction and thermal injury, neuropraxia. The nerve looks perfect at the end of the case and the face still does not move, which means the discipline is not only about avoiding the blade, it is about not stretching, not retracting hard, not applying bipolar close to the surface, and not leaving the nerve exposed and drying for long periods. Now the specimen, closure, and what comes after. Which branches you dissect depends on where the tumor sits. Anteriorly, in this case, keep a cup of tissue all around. Free the tumor completely, work around it, preserving the branches separately, the specimen off its bed. At the end, it remains attached to the parotid duct, usually. Cross clamp, bipolar, cut and deliver. On the specimen, parotid tissue all around, or the tumor a little exposed in places that is expected and is not in itself a failure of technique. Irrigate the bed with saline, perform a Valsalva to look for venous ooze, stimulate the main trunk again and watch for the full face move. That is your record that the nerve is preserved. Closure, facial layer is approximated with muscle, a suction drain position so that it is not in direct contact with the branches, subcutaneous stitches with a flap approximated so there is no malposition of the pinna, then subcuticular absorbable sutures. That last detail is the part the patient examines in the mirror. 3 things to counsel about afterwards. Transient facial weakness is common and the reported incidence varies widely across the series depending largely on how carefully it is looked for. Permanent weakness after surgery for benign disease should be uncommon. The marginal mandibular branch is the most common, vulnerable, having the fewest interconnections and the least redundancy. Frey's syndrome, the gustatory sweating is the elegant one. The auricular temporal nerve carries postganglionic parasympathetic secretomotor fibers to the parotid. Divide them during the surgery and they regenerate. But the parotid is gone and the nearest available targets are the sweat glands and the cutaneous vessels of the overlying skin, which are normally sympathetically innervated by the fibers using the same neurotransmitter. The parasympathetic fibers re-innervate them. The result is a patient who sweats and flushes over the cheek when eating because the salivary reflex now drives the sweat glands. Ask patients and a minority report it. Test with starch iodine and you find it in most. First bite syndrome, intense cramping pain in the parotid region with the first mouthful, easing over subsequent bites, is rarer and relates to the sympathetic denervation, worth naming because a patient who has not been warned finds it alarming. The bottom line, the trunk is not found by a landmark, it is found in the tissue between the two landmarks. One tested layer at a time and with a simulator confirmed before it is trusted. And the patient to keep taking layers until the nerve appears. The full step-by-step video is linked in the show notes. Subscribe for more operative head and neck surgery. This content is provided solely for professional surgical education. It does not replace supervised operative training, institutional protocols, or individual clinical judgment. Until next time, thank you.